This conference will now be recorded.
Hello, good morning. So I have dealt with all the items in the cardiovascular system. Now I would like to tell about the examination of cardiovascular system, which is essential for your practical exam. And you should know all those things. So first, first is the history is very, very important in the clinical diagnosis. So without history, you cannot make out unless it is an emergency one where you can make out a maybe possible you can make out. Otherwise, history will give you unless the patient is unconscious. So in those cases, history you should take from the attendant. Otherwise, it is very, very difficult to make a diagnosis. So history-wise, so usually in a cardiovascular system, the cardinal symptoms are the chest pain, breathlessness, palpitation, syncopal attacks. So these are the very vital. So these are the cardinal symptoms of the cardiovascular system. You should write or you should know about these things. First is the chest pain. So chest pain, there are so many causes which can produce chest pain, starting from angina or myocardial infarction to the either a subcutaneous skin infection or the trauma like that or inflammation of the chest wall. So there are various causes, but usually you should know whether it is a cardiac or non-cardiac because the treatment differs in each case. So in the history, you should ask about the site of the pain. So the retrosternal pain. So this is the most important thing in the cardiovascular system where it can occur due to the involvement of the myocardial infarction or it can be due to pericardial disease. There are other diseases, other symptoms, chest pain can occur. So below the sternum, there are other structures like the esophagus is there, is it not, and then pleura, and then lymph nodes are there. So or neural tumor, these are all can produce the chest pain. But regarding the cardiovascular system, the patient complains of retrosternal pain, and then it radiates. There are, depending upon the site of the infarction, the pain may radiate either downwards or along the left border, ulnar border. So usually it radiates along the ulnar border of the left hand and rarely to the epigastric region. Epigastric region indicates it is due to the inferior wall MI, or it may radiate to the both the jaws or posteriorly. There is a posterior MI, is there posterior wall MI, the pain can radiate to the back. So these are all the sites where it can radiate, not only on the ulnar border of the left hand. Then nature of the pain. So this is also very important to know. The nature of the pain, it may be minimal discomfort to severe agonizing pain. Sometimes they may not have any pain also. So usually a patient with a diabetes or elderly individual, that means more than 80 years or 90 years like that, in those people, in myocardial infarction, they will not have any chest pain, but they will come with a breathlessness, sweating, syncopal attacks like that. These are what are called as angina equivalents. So the nature of the pain may not decide the type of the disease. In myocardial infarction, basing on these things, the pain may be minimal discomfort to severe agonizing pain can be there. And the duration of the pain, this is also very, very important to know to differentiate a cardiac from non-cardiac. Usually a cardiac pain, the pain will be present in the retrosternal area and it will be less than 15 minutes in angina. And in case of myocardial infarction, it may be more than half an hour, 1 hour, more than 1 hour or 2 hours. Till the spasm of the coronary arteries are relieved, patient may have pain. So the duration of the pain is very, very important. So if it is less than 15 minutes, you have to think in terms of an angina. Whereas if it is hours to get 1 or 2 or 3 hours are there, the severe agonizing pain can be there. It may be due to myocardial infarction. Whereas in non-cardiac cases, it may be present for few hours or few days, and it is related to the either a respiratory, that is cough or like that, cough, breathlessness may be present, indicating of a respiratory. So non-cardiac pain may persist for a longer time when compared to cardiac disease. And then what are the aggravating factors and relieving factors? Anywhere you have to ask the site of the pain, radiation of the pain, nature of the pain, and duration of the pain, and aggravating and relieving factors. Usually in case of a cardiac pain, either myocardial infarction or angina, the pain will be aggravated after physical exercise or emotional disturbance. So this will be aggravated. Whereas in case of the relieving factor is usually taking rest or taking some drugs, already known cases there. So if the patient takes nitrates, so patient may have relief. So it may be relieved by taking rest or taking drugs. Now, the other important symptom, associated symptoms. So these are also very important. So if a patient comes with a chest pain and may have vomiting, now the vomiting can be there. That is suggestive of a inferior or MI. So the patient can have severe vomitings can be there. Profuse sweating. Sweating, this is due to the sympathetic overactivity. Vomiting can be due to parasympathetic activity. And then they can have breathlessness and then syncopal attacks. Breathlessness is due to the acute left ventricular dysfunction. So pulmonary edema may be the cause. And then syncopal attacks are due to the hypotension or cerebral anoxia can produce. So these are all the symptoms you should ask whenever a chest pain. So now previously we used to think after 45 years if the patient comes with a chest pain with all these, you are thinking in terms of a myocardial infarction. But nowadays even a 30-year fellow also may have chest pain and myocardial infarction symptoms can be there, suggestive of MI in younger individuals because of various risk factors. So nowadays, even in case of COVID infection, even young people are getting MI pain and then suddenly they are collapsing because of the thrombotic attacks occurring in COVID. That means COVID virus infection, COVID-19. So nowadays we are getting these. So patients are complaining of sudden chest pain followed by unconsciousness and other things are they are dying due to hypotension and other things. So chest pain is a very, very important symptom in case of a cardiovascular disease. Next comes the breathlessness. So whenever patient complains of shortness of breath, we should ask what is the duration, how long patient is having. So is it in minutes or hours? Because the diagnosis changes basing on the attack of the breathlessness or shortness of breath. If it is of sudden onset, so acute attacks we have to think of whether it is due to cardiac disease or a non-cardiac disease like bronchial asthma and other things or pulmonary infarction. So like that, so is it a sudden onset or a gradually progressive? So in the initial stages of cardiac disease, so patient may have increasing breathlessness. So that is, it starts with the grade 1 to grade 4. And so that is chronic, the patient is going for heart failure like that. So the duration is important. It is sudden onset or gradually progressive. Sudden onset in case of cardiovascular system, you have to think of acute left ventricular failure. You have to think of because of pulmonary edema, the patient will have sudden onset of breathlessness. Now next comes the grading. So grading according to NIHA's classification. So the grading we have to make grade 1, grade 2, 3, 4. So grade 1 is unaccustomed exercise. If a patient gets a breathlessness for unaccustomed exercise, so you can call it as grade 1. Grade 2 means accustomed exercise. That means when they are routinely they are doing work like walking to the hospital or whatever it may be, or climbing stairs. So for that activity, if they develop breathlessness, that is grade 2. So unaccustomed exercise, grade 1. Accustomed exercise, that is grade 2. Grade 3 is the minimal. So suppose if the patient is walking in the house or going to lavatory or bathroom or kitchen like that. So if they develop for walking for 2 hours, that is grade 3. Grade 4 means patient is breathless even at rest also. So you have to ask which type of which grade he belongs to. So in case of a cardiac failure, say they may start with first grade 1 and gradually progresses to grade 4 breathlessness. So the duration of breathlessness and then onset of breathlessness. Next comes the grading of the breathlessness. And another two important things you should ask in the history whenever a patient comes with the breathlessness. That is a PND and orthopnea. PND means paroxysmal nocturnal dyspnea. So that means patient will be normal while the routine in the morning and other things, and then when he goes to the bed also he will be normal. But suddenly in the middle of the night he wakes up because of increasing breathlessness. So then he has to sit and walk few yards, a few steps he has to go to the window to get the ventilation, and then he may have some relief in the breathlessness. So that is what is called paroxysmal nocturnal dyspnea. So if any patient comes with the history of PND, even if it is the first time, so you have to exclude the presence of cardiac disease. This is the very, very important symptom which is suggestive of a cardiovascular system. So PND is nothing but when the patient goes to the bed and sleeps for a few hours, then what will happen? So during sleep, the ventilatory, the effort will be, respiratory effort will be reduced, and then brain center is also less active, and then so there will be venous congestion. During that posture, there will be venous congestion will be there. So that's why normal heart can cope up with this, but when the patient has got a diseased myocardium or a cardiac problem is there, so this cardiac congestion will worsen the symptoms. So heart cannot cope up the extra load. So that's why you will have the breathlessness. And once he sits, so when he gets the breathlessness, if he sits, there will be redistribution of the fluids. And if he walks for few yards or few steps, if he puts, so the breathlessness will be decreased. So that is what is called PND. This is the very, very important symptom of a cardiovascular disease. Another thing which can be confused is the acute bronchial asthma. So usually in case of acute bronchial asthma, it occurs in the nights. Once again, the patient will be normal, and because it is a paroxysmal in the middle of the night, or sometimes he may have breathlessness. So that you may mistake it for the bronchial asthma. So to differentiate, you have to ask the history of if the patient is getting repeated attacks in the night, seasonal variation or allergies, if they are present, that is more in favor of a bronchial asthma. If it is not there, it is in favor of a cardiovascular system involvement. And another important symptom is orthopnea. So orthopnea indicates the patient is going for grade 4. So where patient will be comfortable in the sitting posture rather than in the supine position. So PND and orthopnea, these are most important symptoms which clinches the diagnosis of a cardiovascular system disease. So you have to ask this whenever a patient comes with the breathlessness. And the third important symptom, that is palpitation. So palpitation means awareness of the one's own heartbeat. Usually we are not aware of the heartbeat. Suppose a patient complains that he is aware of his heart is beating either irregularly or fast. So that means that is what is called as palpitation. So once the patient tells dada, hunde dada, they will tell. So in that local language. So if a patient complains of palpitation, so that means once the patient complains this symptom, we should ask whether it is continuously present throughout the day or is it present intermittent. Intermittent means for a paroxysmal. So now and then it comes and goes. That means you have to think of arrhythmias which are occurring intermittently, either atrial ectopics or ventricular ectopics, or it could be due to the atrial fibrillation or other things. You have to think of it. Continuous means continuous tachycardia, tachyarrhythmias. So usually in case of anemia or whatever it may be, where so the tachycardia is there, so that can produce a continuous palpitation. Unless you treat the underlying cause, patient or a fever is there, so he may have continuously palpitation, can be there. So whenever a patient complains of palpitation, you should ask whether it is a continuous or intermittent. Now, once the patient complains of palpitation, we should ask how they are relieved. So usually, in case of atrial arrhythmia, so usually paroxysmal atrial tachycardia, so they are relieved by vagal stimulation, where it can reduce the heart rate and patient can have relief. Like tickling of the fauces can be there, or massaging the side of the neck. So where there are receptors are there, baroreceptors, carotid receptors. So they will, vagal stimulation is there, and that can produce the reduction in the heart rate, and patient can have relief, can be there in case of a atrial, paroxysmal atrial tachycardia. So that is, so how they are relieved is also important. Or if they take rest, usually ectopics and other things, so they may have some relief when they take a rest. So like that. So what are the various factors which can relieve or exacerbate the palpitation? So So this is the important thing which was asked in the history. And the other important thing is a syncopal attacks. So what is a syncope? A syncope means a transient loss of consciousness. So less than few seconds. So then it is a syncopal attack. So whenever there is a blood supply, cerebral blood flow is reduced, so that can produce the syncopal attack. So once the patient tells a syncopal attack, you should ask, is it related to the posture? So usually in case of hypertensive individuals, so in the early morning, if they wake up and if they stand, immediately they will complain of syncopal attack. That is postural hypotension can produce a syncopal attack. Or otherwise, in case of wherever there is a cardiac output is low, as in case of aortic stenosis, mitral stenosis, or in case of severe hypotension. So in all these conditions, the bradyarrhythmias, tachyarrhythmias, all these can produce or even myocardial infarction. So in these conditions, patient can have a syncopal attack. So you should ask when the patient gets a syncopal attack and is it related to the posture, early morning posture, whenever he stands, then patient gets the syncopal attacks, that is postural hypotension. So these are the questions. And in case of seizures also sometimes, so the patient may complain of a syncopal attack. So that is the importance of the syncopal attack. So whenever there is a cardiac output is reduced, so that can produce the syncope. Another important thing, cough, expectoration, and hemoptysis. So you remember whenever a patient comes with a cardiac disease, the first symptom is the breathlessness, then comes the cough and expectoration. Whereas in case of a respiratory disease, first it is the cough, then later the patient can have breathlessness. So because in case of a cardiovascular system disease, the breathlessness is first because of the pulmonary edema. Later, the patient may have cough and expectoration, other things. Whereas in a respiratory disease, the first symptom is the cough, expectoration. Then if the patient is a progressive disease, then the patient may go for the breathlessness, or in case of a bronchial asthma like that. So cough, first cough, fever, cough, expectoration, respiratory disease, whereas breathlessness, cough, expectoration is a cardiovascular system involvement. And the next thing is the hemoptysis. So hemoptysis, it can be due to a respiratory disease or it can be due to a cardiovascular disease. So usually in case of a cardiovascular disease, so hemoptysis, that means a pink frothy sputum, that indicates it is due to pulmonary edema, that is left heart failure. Whereas hemoptysis, respiratory diseases, commonly you can get in case of a tuberculosis or a malignancy, so or bronchiectasis, lung abscess. So these are various causes which can produce hemoptysis. So in those people, first will be cough, expectoration, and large quantities of sputum can be there, and then followed by hemoptysis, malignancy. You have to think of. Whereas in case of cardiovascular disease, the first pink frothy sputum indicates a pulmonary edema, or in case of mitral stenosis, the patient can have hemoptysis, that is due to the pulmonary arterial hypertension, where there is a apoplexy. So there is rupture of the pulmonary arterioles, and then the patient can have hemoptysis. Or in case of mitral stenosis, so because of the winter bronchitis. So these are the two explanations, or other explanations are there which can produce a hemoptysis in case of a cardiovascular system, especially in case of a mitral stenosis. So these are the three things we can ask to rule out the complications. And then cyanotics, even hemoptysis can occur also in aneurysmal rupture. If there is an aneurysmal rupture, thoracic aorta, aneurysmal rupture also, the patient can have hemoptysis. Or the drugs patient is taking sometimes can produce hemoptysis. Next is the cyanotic spells. So cyanotic spells indicate the patient is having a cyanosis, that is right to left shunt is a common thing. Or if the patient, in the case of a congenital heart diseases like TOF, so tetralogy of Fallot, where the patient can have cyanotic spells whenever a patient is exerted, say the child is playing, suddenly the increasing breathlessness can occur with a cyanotic spell. So that is a cyanotic spell, or it may be due to the respiratory causes also. If there is a respiratory failure, they can have. But usually cyanotic spells indicates right to left transfer, especially TOF, that is the commonest thing where you can find cyanosis, or a severe congestive cardiac failure also patient can have a cyanosis. Now the other important thing, that is bluish discoloration of the mucosa, you can tell. And next is the swelling of feet. So swelling of feet, distension of abdomen, pain abdomen. So whenever a cardiac case comes with a swelling of feet, you have to think in terms of a right heart failure. So the common symptoms of right heart failure are the swelling of feet, distension of abdomen because of the accumulation of fluid in the transudate in the abdominal cavity, peritoneal cavity, producing distension of the abdomen, and the pain abdomen. This is another important symptom which make you to diagnose a case of right heart failure. So pain abdomen is due to the congested liver and spleen also sometimes. So liver pain, usually they complain of pain in the right hypochondrium because of the congestion of the liver. So these symptoms suggest of a right-sided. So left-sided symptoms are usually breathlessness, and then syncopal attacks, and then other cough and other things can be the PNG and orthopnea. Whereas right-sided symptoms usually swelling of feet, distension of abdomen, and pain abdomen you have to think of. And other things are urinary symptoms like polyuria or anuria. So these can occur in case of whenever the cardiac output is reduced, and then renal this one is reduced, renal circulation, the renal impairment is there. So patient can have oliguria or anuria because of the less blood supply to the kidneys. And loss of appetite, loss of weight. So usually loss of appetite and loss of weight indicates a patient may be going for a chronic, patient can have cachexia, cardiac cachexia patient can have, or congestion of the liver and the stomach can produce the loss of appetite can be there. Squatting. So this is an important one, which is a feature of a TOF, that means a tetralogy of Fallot, where the patient will have, whenever he gets breathlessness, he will keep his both hands, both elbows over the knees. So in that posture, he will have some relief. That means in that posture, the systemic this one is pressure is increased when compared to pulmonary artery. So that's why patient may have relief. So whenever a child complains of cyanotic spells and the squatting improves the cyanotic spell and the breathlessness, that means we have to rule out the presence of the tetralogy of Fallot. Stokes-Adams attacks. This is also because of the decreased cerebral blood supply. So patient can have seizures attacks. So that is after 3 minutes of the cerebral perfusion is reduced. So first initially they have syncopal attack, then they may go for the seizures, and finally patient goes into coma. So that is the importance of asking of a Stokes-Adams syndrome, Adams effects in case of a cardiovascular disease. And another important, to know the etiology of the cardiovascular disease, you should ask pain with a prolonged fever. So usually female patients coming with a prolonged fever and joint pain, usually indicating of the involvement of the major joints or small joints also sometimes. So you are skin rashes are present. You have to think in terms of a connective tissue disorder. Now coming to the past history. So past history you should know, because of the, to know the etiology of the cardiovascular system involvement, a rheumatic fever. So how to ask the history of rheumatic fever? Usually children is more common. So a patient may come with a sore throat, and then later fever can be there, and followed by migratory polyarthritis. That means patient will have pain. Usually the major joints are affected, like wrist, elbow, knee joint. So in these conditions, patient will have pain, joint pain, fever, joint pain will be there. And then one more thing, a fleeting type of joint pain. That is what is called migratory joint pain. Where, so today the pain may be in the knee joint. So after one day, the patient may have pain in the elbow joint. Like that, it will be migrating from one joint to another joint. That is what is called migratory polyarthritis. So a children or in an adolescence, a patient comes with history of fever, sore throat, and migratory fleeting type of joint pain. You have to think in terms of a rheumatic fever. You have to rule out it. So other causes can involve, so say tuberculosis or Other thing, rheumatoid arthritis means usually the smaller joints are affected first, whereas if it is due to tuberculosis, usually single joint is affected, or even septic arthritis. So like that, we can rule out the etiology for the joint pains. Next is the hypertension. So hypertension present later leading on to cardio. So is the patient known hypertensive, taking treatment or stop treatment or on irregular treatment, you should ask regarding the hypertension. So next is the diabetes. So usually diabetes will worsen the atherosclerotic process and the patient may have a cardiovascular disease. So history of hypertension and diabetes, ischemic heart disease. Suppose the patient is having ischemic heart disease and now he had a MI for a few months or years back, and then suddenly he comes with the breathlessness and other things. So either is it ischemic cardiomyopathy like that. So history of ischemic heart disease is also important. Now the other important possibility in our country, in our non-developed or poorly developed countries, so tuberculosis is the commonest thing. So tuberculosis can involve the pericardium, producing tuberculous pericarditis, or even the blood vessels also can be a Takayasu disease, that is also tuberculosis. So history of tuberculosis is also important, you should ask. And then we have drugs. So usually some drugs can HIV, usually anti-retroviral heart therapy, if the patient is using those drugs and then coming with the heart failure, so is it a drug induced or not? And then history of asthma. So history of asthma is very important. So how to ask the history of bronchial asthma is seasonal variation, history of allergies is most important thing, and then atopic skin lesions. So or multiple drug allergies. So these are suggestive. If the patient of this pattern comes with a increasing breathlessness, you have to rule out the presence of a bronchial asthma. So these are the important things you should ask in the past history. So personal history, of course. So history of smoking. Smoking can also worsen the atherosclerotic process, and also it can involve all the organs in the body. Smoking is the worst thing which can affect the organs. And then alcohol. So alcohol usually produces alcoholic cardiomyopathy. That is one thing. So myocardial involvement is there, or it increases the atherosclerotic process. In both ways, the heart can either direct or indirect. So it can involve the heart, or in case of beriberi. So this can also due to chronic alcoholism. So history of alcoholism is important. So alcohol means you should ask the duration of the alcoholism, how long he is taking. Suppose if he takes on and off, once in a month, once in 2 months like that, or whenever he is having some party like that, then if he takes, he is occasional. Suppose if he takes regularly, daily he takes or consumes alcohol, and then brand also you should ask how many years he is taking. That is also an important thing you should ask whenever the patient is consuming alcohol. Drug addictions. So usually the drug addictions, commonly cocaine, so that can involve the cardiac muscle, and the patient can develop the cardiomyopathy, or even hypertension can be there. So that is the infective endocarditis. There are so many things which can occur in drug addicts, where they take intravenous route without unsterile needle. So right-sided infective endocarditis is common in drug addiction. And then sleep pattern. So sleep pattern, usually if the patient complains the night time, I am not able to sleep, suddenly I will get breathlessness. So that is indicative of PND. So usually suggest that may be due to the cardiovascular system involvement. And a female, you should ask about the menstrual history and obstetric history. So obstetric history is important because so when the patient is having symptoms prior to the pregnancy, so that means already pre-existing cardiac problem is there, is maybe hypertension or a valvular disease can be there. Suppose if the patient complains of breathlessness and other things during the pregnancy, that is the first time developing in pregnancy. So after 20 weeks with the patient pregnancy, if it develops hypertension, that means PAH. Or if the valvular disease is there, say mitral stenosis, so patient may have worsening of symptoms, sudden onset of pulmonary edema first time in the pregnancy. So you should think of an obstetric history is very, very important, whether the patient has a pre-existing cardiac disease or due to pregnancy, patient can develop the cardiac problem. So postnatal, that is in case of a postpartum cardiomyopathy, that means after delivery. So within 6 weeks of delivery, if the patient develops heart failure, so you have to think of a postpartum cardiomyopathy. You should think of. Like that, the obstetric history is important. And treatment history is, so whether the patient is taking any injections, white injection you can ask. So that means penicillin injection is he taking every 3 weeks a month. That means the patient had a rheumatic fever and he is taking the prophylaxis. That means you have to exclude which cardiac problem he has. These are all the important things you should ask in the history. Now we'll go for the, now after asking the history, then the general examination, that is the most important thing. So you should examine the patient as soon as he enters into your OPD. So how he looks. So I'll tell you what are all the things you have to look for. So, so what are the physical signs? These are the manifestations the doctor finds during the examination. Certain abnormalities in general examination may help you in the diagnosis and assessment of the cardiac patient. So general appearance. So that means the patient's physical development, if it's normal, so we can exclude a congenital heart disease. Suppose a patient comes with the developmental problem is there, stunted growth is there, child that comes, or a 20 years fellow appearing as a 10 years fellow. So you have to think of some congenital anomalies of the heart. So like that, the physical development is also important. Now, evidence of pain. So evidence of pain means if a patient comes to casualty with severe agonizing pain, you can see the facial of this one. So whether he is suffering with the pain of it. So usually in case of angina or in the myocardial infarction, so usually or in aortic dissection where the patient will have severe pain. So by looking at his face, you can make out he is having some problem with the pain. So usually you have to exclude these things. And evidence of heart failure, as I told you, is it a right heart failure or left heart failure? So right heart failure means they will come with edema of it and distension of the abdomen, like that you may find it. And color complexion of the patient. So in cyanosis, whether the cyanosis is present or not. Or fingers. Fingers means mainly you have to look for either a clubbing or other Marfan syndrome. There are so many things which you have to observe in the fingers. Or is there any cyanosis is there? Chylomicria is there, indicative anemia of congestive heart failure. These are all the things you have to observe in the general examination. And evidence of any generalized disease like a connective tissue disorder is there. So any generalized disease is there, you can make out in the general. Apart from your routine things, you have to see these things. Vital signs I'll tell you later. So somatic infantilism is a retarded physical and mental growth in case of severe cardiac disease starting in the childhood. Whereas in cachexia, in advanced heart failure in an elderly man or an adult, if he comes with severe cachexia, it may be due to chronic cardiac failure. You have to think of it. Now in the general examination, as you are seeing, so build, nourishment, failure, jaundice, so pickle you are telling. So build is nothing but it will not indicate the nutrition of the person. So build indicates is it athletic build or asthenic build or sthenic build. So usually that indicates the skeletal frame. So if a patient is athletic build is there, so he will be tall and then so muscular build. So that means indicates athletic build. Whereas asthenic means short and then stout face. That means that is a sthenic build where you can think of either endocrine disease or it can be due to diabetes and other things you can make out. Whereas in case of a thin build, you have to think of nutritional disorders or infections, commonly tuberculosis and other things can be. So build, sthenic, asthenic and or respiratory diseases are common in case of a asthenic build you can make out. So build is important, then so you can don't write moderately built. So usually you are still writing moderately built, that you have to write as asthenic, sthenic or this one you have to mention. Nourishment. So nourishment means you have to make out whether there is a poor nourishment. So either minerals, so that is iron deficiency is there, or vitamin deficiency is there, or calories are deficient, or the fluid, that means the dehydration, or dehydration present, or is it due to the calories which can obesity. So nourishment, poor nourishment, or overnourishment, that means obesity is there. So is there any maladjustment in the nourishment? We have to think of nourishment means not, we should not think only the poor. So you have to think of other side also. That is the obesity. That now it is common in the people because of eating so many foods which are unwanted. So nourishment is important. Then pallor. So pallor means you have to see, usually you have to see the lower palpebral conjunctiva, tongue, and then hands, and then feet, you can, or entire body. Pallor indicates there is a reduced hemoglobin, which indicates the patient may be having anemia. So there are other conditions are there because of the pituitary deficiency. Sometimes we may found pallor. So that is entirely different. So pallor means you have to see the lower palpebral conjunctiva, then the tongue mucosa you have to look for it, and then hands, and then over the nails you can, nail bed you can see, and entire body. So that is pallor. Next is the jaundice. So jaundice, where you have to see the usually the sclera you have to see, and the mucosa in the oral cavity, or the inner aspect of the lip, and then forms in feet or entire body. That is due to the presence of increased bilirubin content, which can produce a icterus present. And cyanosis, I'll tell you, cyanosis is the bluish discoloration of the mucosa. So this can be due to either a central, I'll tell you later in detail about the cyanosis. So if cyanosis is present, we have to see whether is it due to a central cyanosis or a peripheral cyanosis. So what are the things by which you can make out whether it is a central cyanosis or a peripheral cyanosis? The clubbing. So clubbing is another thing which you will find so many cardiac involvement, respiratory involvement, gastrointestinal causes. There are so many causes which can produce a clubbing. I'll tell later. So you must look for the clubbing. So then chylonuchia. Chylonuchia means spooning of the nails. So that will be seen in case of iron deficiency anemia. So the anemia due to other causes will not produce the chylonuchia. It is only the iron deficiency anemia which can produce a chylonuchia, where the patient will have the flattening or the spooning of the nails will be made out. Pedal edema. So pedal edema is usually seen in case of a right heart failure. So in the history, if you ask the pedal edema, suppose how to differentiate when a patient comes with anasarca, is it a cardiac or a renal disease or a GIT? Suppose in case of a GIT, usually first the abdomen dysfunction, then comes the swelling of the feet, and finally the face, entire body. Whereas in case of cardiac disease, so usually the edema appears first in the legs. So that will be more during evening. So that is the typical history within a cardiovascular system. Then comes the face and abdomen. Whereas in case of renal disease, the edema first occurs around the eyes. So periorbital edema during the early hours of morning. When he wakes up, he will make out the periorbital edema. Then comes the lower limb and finally abdomen. So the mode of onset can give you a clue whether it is a cardiac disease or a renal disease, or is it due to the cardiovascular system. You can make out. So that once again, if you see the edema, you have to look for whether it is a pitting or non-pitting edema. So pitting edema indicates cardiovascular, or pitting means the fluid accumulation. If you press over the medial malleolus, so you can make out a pitting. So that indicates either a patient may be having cardiovascular or a renal system involvement or a GIT or hypoproteinemia. You have to think of it. Whereas is it unilateral or bilateral, you can mention. And the lymphadenopathy. So lymphadenopathy, once again, you have to look for, is it a generalized lymphadenopathy is there? So usually you have to look for cervical group of lymph nodes, axillary group of lymph nodes, inguinal group of lymph nodes. So these are the things we have to examine and say whether all are enlarged or what is the specific nature. So you have, whenever you are examining a lymph node enlargement, you have to mention the site of the lymph node, and then what is the size, And then how many numbers are there? Then is it when palpating, you must look for whether there is any tenderness present, and then consistency, is it a for soft or stony hard. And then we have to look for the whether it is underlying tissues, is it infiltrating. So when you move the lymph node both in vertical and horizontal axis, if it is infiltrating into the deeper structures, that will not fix it, the lymph node will be fixed. So you have to look for whether it is fixed to the underlying structures or not. And you should not forget that you should examine the drainage area also, you should examine. And one more important thing, whenever a patient, that is a dictum, whenever you are examining a lymph node, you have to examine the spleen. You should not miss the spleen. So reticular endothelial system, so that will include spleen also. So whenever you find any patient with a lymphadenopathy, you have to look for a splenomegaly present or not. So these are all the things we should look for in the general examination. And apart from that, in a cardiovascular system, there are certain things we have to examine. So that is a Marfanoid features. Marfanoid features indicate, so that indicates a patient may be having the involvement of the heart, or aortic regurgitation can be there, or mitral valve prolapse can be there. So that is a Marfanoid features. So where you have to measure the arm span. So I'll show what are all the things in detail in the next class. I'll tell you. Arm span you have to measure, that is from the tip of one and to other. So extended hands, you have to from the middle finger, you have to measure it. Wrist sign, thumbs, and always I will show you later thumb sign and other. So are there any other congenital anomalies? High arched palate. So how to know patient is having high arched palate means you keep the head like that, and then parallel to the incisor, if you throw light and then see, usually you can see the palate, hard palate you can make out. Suppose if it is not seen, so that means patient is having a high arched palate. Iridodonesis, that is you can observe the lens moving, iridodonesis, dancing of it. Pectus excavatum, that means that the sternum is concave, depressed chest, that indicates pectus excavatum. So these are all the findings which are suggestive of Marfanoid features. So any patient, so thin, long individual with increased arm span, wrist sign, thumb sign present, and other anomalies if they are present, you have to think of a Marfanoid features. In those people, you have to exclude mitral valve prolapse or aortic regurgitation, other things are present or not. Low CTR, low hairline, all these suggest some congenital anomalies. So a patient with a adolescent or child with abroad, you have to see all these things. Down syndrome, that is one more thing. So we have to look for, so that means a single palmar crease and then slanting of the eyes and other. So these people may have a cardiovascular disturbances like anomalies like ASD, VSD can be there in a Down syndrome. Polydactyly, extra digit, that means polydactyly, or syndactyly, that means two fingers united. Polydactyly. These indicate the patient, you have to search for the any congenital anomaly patient is having. Earlobe crease. So if you find a horizontal earlobe crease, that means patient may be having hypercholesteremia. So you have to rule out whether you have to see for the atherosclerotic features, and then lipid profile you have to look. And then thyromegaly, so thyroid enlargement. So it can also involve during second, either in hypothyroidism or hyperthyroidism. So both can affect the heart. So patient may develop hypertension or thyrotoxic heart failure, or usually heart failure can be the feature, or any arrhythmias can be there, or involvement of the, in case of hypothyroidism, pericardial disease, pericarditis, pericardial effusion are common. And then rheumatic nodules. If you find nodules near the joints, especially in the elbow joint or the knee joint, so rheumatic nodule, is it a rheumatoid or rheumatic, or so you have to rule out by if there are nodules are there, you have to examine. Nicotine stains over the fingers. So usually over the middle finger, if you see the nicotine stains, the patient may bluff, I am not smoking. But if you find nicotine stains, that means the patient is a chronic smoker. Osler node, John V node, these are all indicative of a infective endocarditis. Mental changes means depression. So following myocardial infarction, because you will be thinking whether I will be alive or not. So there are so many, so it may produce a depression. And the restlessness, lack of concentration, lethargy or confusion, that indicates that may be due to hypoxia or electrolyte imbalance, either hyponatremia. So that can produce a electrolyte imbalance. And cerebral atherosclerosis in elderly individual. So cerebral atherosclerosis. Evidence of pain, so myocardial infarction, where the patient will be depressed, pain, cold, and sweating. Whereas in pericarditis, usually pain patient may be having discomfort and prefers to sit up and lean forward. So that is the most important thing when you observe the patient. When the patient is having pericarditis, they will be leaning forward to get relief from the pain. So that is one of the postures. And respiration, you will be able to take a deep inspiration. That is also sometimes indicative of a pleural diseases also. Complexion, ఇంకా చెప్పొచ్చా? అయిపోతే చెప్తాను. Next, complexion means pallor. So pallor indicates anemia. So this is the cause for the heart failure. Molar flesh, I'll show all the signs, all those. Molar flesh, that means a mitral stenosis over the molar region, you may find discoloration. That is molar flesh. Cyanosis, so that may be due to right to left side or a pulmonary edema. A plethora means a flushing of the face. So that indicates a polycythemia or alcohol abuses or Cushing's disease. These are all Cushing syndrome. You can find plethora over the face. Pigmentation over the legs, that indicates that is a chronic right-sided heart failure. Jaundice usually indicates a cardiac cirrhosis or it can be due to pulmonary infarction. So this is the mitral faces where you can see over the both cheeks, you are able to see the discolor, that is mitral face. This can be observed in a fair individual, you can make out. Cyanosis means bluish discoloration of the lips, you are able to make out. And then this is the high arched palate. So the Abraham Lincoln, he had a Mark 1 syndrome, I think. So he had a high arched palate here. So I told you how to examine for the high arched palate. Then eye signs, that is you can find a whitish ring around the cornea. So that means a corneal arcus. So that indicates. ఇంకొక 10 నిమిషాలు తీసుకుంటాను. చేసేసారా? ఆఫ్ చేసేస్తున్నా అయితే. ఓకే. So thank you. I will show all these things in the next class. So stop. ఇంటికాడ నుంచి తీసుకోండి.